Hi, thank you, everyone. Thank you for inviting me, Arthur. I really feel unfortunate that I couldn't bring Krakow this year due to personal issues. Um, but I'm still very thankful that you gave me the opportunity to give this talk and be part of your meeting. So, I'm going to speak today on clinical and prognostic significance of immune recovery post treatment in myeloma. So, first of all, we all know, as myeloma physicians, myeloma patients have a significant immunodeficiency. And the question is, okay, so what? Is it really important? And the answer is yes, it's highly important. One second. Sorry for that, but can you see my slides? Because I haven't put it on full screen. Is it fine? I hope so. Okay, so the question is why is it important? And we know that there is increased incidence of infections in patients with myeloma, but also in patients with MGUS, as you can see here in this figure. And moreover, we know that the second cause of death in patients with myeloma is basically infections. And we know that patients have an increased risk for bacterial infections, but also for viral infections. And this is something which is really, really significant. And you can see here that the incidence of infection, starts to increase even before the diagnosis of myeloma. However, after patients are being diagnosed with myeloma, the incidence of infection is significantly high during the first year since diagnosis, and patients are reporting on a high number of infections during that period. So the question is, what really happens? We know that patients, as I've said before, patients with myeloma basically started away with MGUS, though we don't always succeed to diagnose them when they're having MGUS. But we know that the journey from MGUS to myeloma is mainly associated with the development of immunodeficiency. And looking at the genomic landscape, it seems like the genomic landscape from MGUS to myeloma is not significantly changing. It's very, very similar in between patients with MGUS and patients with SMM and myeloma, apart of few genes. For example, the EPOC one, which seems to be much higher in patients with myeloma. However, the changes in bone marrow microenvironment are significant, and it seems like patients with myeloma have more suppressive immunomediae compared with patients with MGUS. And why is it? So during the transformation from MGUS to myeloma, it seems like the bone marrow milieu becomes really immunosuppressive. The ratio between CD4 and CD8 is decreasing. There is accumulation of Th1 and Th17 T cells. There is a significant impairment in dendritic cell function, but also in NK function. And there is a recruitment of immunosuppressive cells, for example, regulatory T cells, TAMs, myeloid-derived suppressive cells, and plasmacytoid dendritic cells, all resulting in an induced tumor escape due to the suppressive immune microenvironment. On the other hand, the myeloma cells themselves succeed to escape the immune system. There is a decrease in the expression of AGLA co-stimulatory molecules, together with the shedding of MHC class 1 chain protein A, and there is a higher expression of PDL1 and other inhibitory molecules on the surface of myeloma cells, altogether resulting in immune escape, and the myeloma cells can basically progress, and the transformation from MGUS to myeloma can occur. One second. And we know that there is a decrease in memory T cells and increased terminal effector T cells in myeloma, which means that during the transformation from MGUS to myeloma, the stemness is being lost. And those very important cells, the stemness T cells, are becoming lower and lower. And the number of CD8 memory stem cells decreases over time when the myeloma is progressing. And you can see here that the TSF1 TF, which reflects the stemness of the T cells, is basically highest in patients with MGUS, but becomes much lower in patients who progress into myeloma. And there is also a simultaneous reduction in naive T cells and increase in effector T cells, which are enriched in cytotoxicity signature, for example, the granzyme. But as I've just said, the naive memory T cells, which are most important for gaining an immune recovery and immune function, are becoming lower and lower when disease is progressing. And there is also something which is very interesting. The myeloma cells, induce T cells to have some kind of pseudo-exhaustion signature. It's not a full exhaustion of T cells, but they gain several markers, which tells us that they are becoming in some way more exhausted, and they are less effective when they are reacting against the myeloma itself, but also against other stimulus. And we know that, this immunodeficiency, which I have just, tried to explain, that there is a significant crosstalk between the myeloma cells and their bone marrow microenvironment, involves basically most of the immune cells which exist in the bone marrow and also in peripheral blood. We know that there is a significant deficiency and suppression of the uninvolved plasma cells, resulting in a very significant hypogammaglobulinemia. There is significant malfunction of dendritic cells, which fail to present the antigen to the T cells, resulting in accumulating T cell dysfunction. We also know there is T cell polarization and T cell dysfunction and NK depletion. All of those, become more significant when patients are transforming from MGUS to SMM to active myeloma, and are even more severe in patients with relapsed refractory myeloma. We also know that the disease status has a significant impact on the degree of the immunodeficiency. Patients who achieve complete remission are less likely to have a clinically significant immunodeficiency. However, patients with relapse disease acquire a significant immunodeficiency and have a higher risk, of course, for infections. We also know the treatment regimens affect the immune system, and I'm going to explain it in a second in more details. And of course, treatment schedules also has a significant impact on the immune deficiency, considering that continuous therapy versus treatment-free intervals may be associated with prolonged immunodeficiency, considering the fact that the new agents, particularly monoclonal antibodies, bispecific antibodies, CAR T cells, cause continuous immunodeficiency. And patients that, for example, that had induction followed by an autograft and do not receive any treatment or receive lenalidomide only have a higher chances to recover their immune system. So we know the changes in the bone marrow microenvironment occur early. They contribute to MGUS transformation into active myeloma, and the bone marrow itself has an impact on response to therapy. But what is the exact impact of the treatments we are using nowadays on the immune function? Let's see what happens with the plasma cells. So as I've just mentioned before, most of the anti-myeloma drug have a non-selective effect on MM plasma cells versus normal plasma cells. Therefore, there is a plasma cell depletion resulting in a significant hypogammaglobulinemia. We also know that triplets are more suppressive than doublets, which makes sense. And we know that the degree of plasma cell depletion is in correlation with the agent's potency, which means that, potent agents tend to result in more significant hypogammaglobulinemia. Again, CAR T cells and BiTEs are more likely to induce hypogammaglobulinemia, but however, non-conjugated and conjugated antibodies are also resulting in hypogammaglobulinemia due to plasma cell depletion, more than proteasome inhibitors, which also result in hypogammaglobulinemia, where IMiDs have as a lower impact on a normal plasma cells, though they also affect their function and survival. The degree of plasma cell depletion also depends on the expression of the targeted antigen. So, one second. So, for example, this is our work, which was published in 2021. We have looked on the levels of uninvolved immunoglobulins in patients with myeloma treated with daratumumab for relapsed or refractory disease, second line and beyond. And what you can see here that after the initiation of daratumumab, there was a significant and very rapid decline in the level of the uninvolved immunoglobulins, which was most significant in patients receiving daratumumab in combination with proteasome inhibitors, but but the decrease was to a lower degree in patients that received daratumumab in combination with immunomodulating agents. Similarly, there was also a simultaneous decrease in FLC kappa and also in FLC lambda, of the uninvolved FLC lambda and kappa. However, we know that talquetamab, targeting the GPRC5D, which is predominantly being expressed on myeloma cells, may selectively deplete MM plasma cells and in some way preserve the healthy plasma cells, which might explain the I hope so, the lower number of infections which were reported with this kind of bispecific antibody compared to bispecific antibodies which are targeting the BCMA. And of course, the numbers in this study are very small, and you may argue and tell me, it's too small to say something. We should wait and see whether the incidence of infection is going to be low even in a larger studies. But the fact that the GPRC5D is mainly expressed on myeloma cells versus healthy cells makes me believe that there is a chance that this is going to preserve in some way the function of normal plasma cells, resulting in a lower incidence of infection compared to other bispecific antibodies. We know that the administration of bispecific antibodies in CAR T cells, which, as I've just mentioned, result in a significant and rapid depletion of healthy plasma cells, result in a significant increase in infections, and the infections, can be bacterial, viral, and we have seen, at least in our hands, even very strange infections which we don't really use to see in patients with myeloma. We also know that the treatments that we are giving have an impact on B cells. For example, IMiDs and cell modes have a B cell depleting effect. We all know as hematologists that they are being used, especially the IMiDs, which are being, being used for years. They are highly effective in indolent lymphomas, especially in follicular lymphoma, depleting B cells. We also have data from a patient with lupus erythematosus, which can experience disease remission following the administration of IMiDs and cell modes. And this is something which we also have to keep in mind. T cells. T cells, highly important to keep our immune system working. However, most anti-myeloma drugs have a negative impact on T cells. We know that steroids, proteasome inhibitors, and the bispecific antibodies all result in T cell dysfunction and in some way also in T cell depletion. However, IMiDs and cell modes have a positive impact on a T cell function with a activation of T cells and simultaneously a depletion of regulatory T cells. However, we are doing, as I've just mentioned, the treatments we are giving result in immune insufficiency. The disease itself results in immune insufficiency. But when we're treating our patients, we really hope that, we are going to restore their immune system. We hope that we are going to deplete the plasma cells, the myeloma plasma cells, and allow the normal, healthy immune system to recover. And the question is how to measure immunodeficiency and immune recovery. We can use the very simple method of measuring the uninvolved immunoglobulins, as I've just showed you in our work. However, it is highly relevant in a pre-maintenance area in which people had treatment-free intervals. So, for example, 20 years ago, we used to give our patients induction, autograft, nothing else, follow them without any treatment. In that time period, we could have looked at the levels of non-involved IgG and see whether our patients recovered. However, looking at the uninvolved IgG levels is less reliable when we're using continuously proteasome inhibitors, for example, bispecific antibodies, daratumumab, all resulting in a significant depletion of healthy plasma cells. However, Van Donk in his work, and also us, we have shown that the patients that are getting into the phase in which are receiving daratumumab only once per month have gradually recovering their IgM levels. So we can follow, for example, the IgM levels and see whether there is some kind of significant or some kind of increase in IgM levels reflecting immune reconstitution. But it seems like these methods are not sufficient nowadays due to the fact that, as I've just mentioned, most of the new agents are also affecting um, the healthy plasma cells, and we need to implement new ways to look at B cell recovery, look at plasma cell recovery, for example, CyTOF and other ways, and we also need to have methods to look at T cell function. So we know that patients undergoing autograft experience a robust expansion of CD8 T cells, including antigen-specific CTLs. We know that there is a short-term recovery of tumor microenvironment, of the immune microenvironment, which predicts outcome. So patients that recover their immune microenvironment earlier have a longer overall survival. We also know that Ig recovery, immunoglobulin recovery post-autograft in untreated patients or in patients receiving lenalidomide maintenance have an improved progression-free survival. But usually we are giving, our patients, triplets and either quadruplets. And the question, is what's going on with the immune system of these patients? And I'm going to take you just very quickly through the sake of time through, this very interesting study, which was presented in the last IMS meeting. So I'm sure that you are aware of the MASTER trial, which is a single-arm phase 2 study, newly diagnosed myeloma patients treated with KRD induction, autograft, and MRD-based approach, in which they received an MRD-based response adapted DARA KRD consolidation. And what the investigators did, they have looked at MRD and they have also looked at the B cell and T cell repertoire of these patients. And what you can see here, that the immunoglobulin gene repertoire expands following the autograft, but contracts following post-autograft consolidation. You can also see that the immunoglobulin recovery is delayed in patients receiving post-autograft consolidation, which is highly expected. We also see that the immunoglobulin gene repertoire rapidly expands in the 6 months after therapy discontinuation. And, these data are in line with the fact that, there is a significant decrease in the incidence of infections after the regaining immune reconstitution. So quadruplets result in a profound hypogammaglobulinemia. Immune reconstitution is delayed in patients receiving consolidation. Ig repertoire is rapidly expanding after the cessation of any therapy, and recovery of immunoglobulin repertoire precedes the recovery of immunoglobulin levels. Infections are decreasing before the increase in immunoglobulin levels and the recovery of immunoglobulin repertoire. So if I just want to conclude, we know that immune reconstitution is highly important. It is associated with a significant decrease in infections. Immune reconstitution can be achieved in patients that obtained a good control of their disease. Nevertheless, treatment itself is often attenuating immunity, and continuous administration of antibodies and or proteasome inhibitor-based therapy impairs immune reconstitution. Measurement of immunoglobulin and FLC levels are insufficient for evaluating immune status, and we need new strategies like CyTOF or looking at the B cell and T cell repertoire to try and understand if the immune system is recovering. Moreover, therapies often affect the other immune compartments, not only the plasma cells, and routine tests are not sufficiently sensitive to assess the recovery and function of these compartments. Tailored therapy enabling treatment-free intervals is highly important and is highly desirable. And thank you for your attention.
Thank you very much. Any comments? Professor Skotnicki, please.
Professor Avivi, it's nice to see you. Thank you for showing us Tel Aviv seaside. I hope to see you in the not too distant future. Probably I will visit you in November this coming year, visiting the pre-war Krakowians who are still alive without multiple myeloma in Israel. Anyway, I'm very grateful for your talk regarding immune system in multiple myeloma patient. In the previous session, we have heard that several patients who are still MRD positive could have obtained plateau and they are surviving for many years. Do you think it is because of the immune system keeping in check the so-called smoldering myeloma? And I'm very grateful that you express the fact that some kind of maintenance or consolidation therapy by suppressing immune system could lead to some extent to relapse of the disease.
So basically, thank you for your question. I think that, you're absolutely right. I see it the same way. I think that, first of all, regarding the first part of your question, I do think that, the patients who didn't succeed to get into MRD negativity, but succeed to get sustained response, it seems like their immune system is working nicely. And these patients are usually those who have standard risk myeloma and less likely to be the patients with high risk, high ISS or high risk cytogenetics. These patients are less likely to have a long-term benefit if they didn't succeed to attain MRD negativity. And this is due to the fact that the cells are still there. So I think it's a combination of the fact that the crosstalk between the myeloma cells and the bone marrow microenvironment. And in patients with high-risk myeloma, I guess that the crosstalk is different, and the induction of immune suppression in the bone marrow milieu is stronger, which allow a higher and more rapid progression of the myeloma, which is also due to the proliferation rate of the myeloma cells themselves. Regarding the second part, I think that that I can say that the myeloma treatment are those which are pushing relapse, but I think that the fact that we are attenuating the immune system, there is it costs. It's not like saying, okay, we can give treatment and forget because we are suppressing the myeloma. I think we should try and continue and find solutions for treatment-free intervals, or at least, give therapies like immunomodulating agents, which in some way keep some of the immune cellular compartments more active, because, we need the patients to have long-term remissions and lower incidence of infections and good quality of life.
And at least we should control on laboratory parameters, the maintenance therapy, control of the immune parameters, just to find out that we are not doing any harm leading to immunodeficiency, as you suggested. Thank you very much.
Thank you.
Thank you. Professor Saha?
Yes, I would have a question regarding the immune reconstitution in the context of CAR T cell therapy. This is the treatment which is administered in very immunocompromised patients in very end-stage disease. So did anybody look at the interplay of those cells after the infusion of those cells, and what is the speed of immune reconstitution in those patients after CAR T therapy?
So the answer is I know, but only for the first few months. I can't say something which I'm sure regarding immune reconstitution later on, because I don't have the data. The data, most of the data are still with pharma companies yet, but we know that after about half a year, there is some kind of B cell recovery and some kind of plasma cell recovery. T cell function, it takes even longer, but I don't have precise data to tell you that effector cells or regulatory cells or all these compartments which are highly important for inducing long-term for immune recovery.
So do you have the impression that the reconstitution is quite similar to this after allogeneic bone marrow transplantation?
I don't think so. At least I can tell you that there are more data regarding immune reconstitution in patients with lymphoma, which is completely different story because they don't have a plasma cell disorder, but it's very different from allogeneic stem cell transplantation because the mechanism through which the CAR T cells are resulting in immune suppression is also very different from allogeneic stem cell transplantation. Allogeneic stem cell transplantation patients also are usually requiring long-term usually for at least 6 months, sometimes even more, of cyclosporine or other T cell suppressing agents. So I think it's a completely different story, but it takes time.
Thank you very much.
It's mainly the plasma cells, but not only.
Okay, I have a question about the MGAS, because it was very interesting to hear that malfunction of microenvironment is the cause of progression to multiple myeloma. Do you know, or are there any, for example, manipulation in bone marrow microenvironment, for example, restoration of dendritic cells, to prevent to postpone the progression from MGAS to multiple myeloma?
So I'm not aware of that. I'm aware of the studies being done by Professor David Avigan with dendritic cells, but not in patients with high-risk SMM, trying to avoid transformation in myeloma. I think it's a beautiful strategy. But I think that the fact that, for example, IMiDs, at least, in the two works that we are aware of, from Sagalonian and from MREV, show that it seems like that it has a significant impact on transformation from SMM to myeloma is due to the fact that we are using agents which are resulting in immunomodulating changes in the bone marrow microenvironment and not just straightforward anti-plasma cell agents. So I'm not aware of immunological studies which are directing exactly this pathway. I'm not aware of strategies that are trying to manipulate the bone marrow milieu precisely, but I think that this is why cell modes and IMiDs are being investigated in patients with high-risk SMM, considering the fact that the immune microenvironment has a significant impact on transformation.
Thank you. Professor Hołowiecki?
Yes, in the former sessions this day, we heard a lot of arguments speaking for new drugs and even for long-term treatments with some immune modulators. So in view of your very interesting data, how would you advise to manage it? For example, with lenalidomide or similar, should we monitor, and if yes, what should we do?
I believe that all these agents are going to be introduced earlier. I strongly believe that if we will be able to identify what we are calling high-risk SMM patients more accurately, because I think that we don't know it accurately right now. I think that we are taking clinical parameters which are not really accurate. If we could have done some kind of a genetic signature of the microenvironment and also of the plasma cells and come up with an algorithm which tells me that one patient is going to progress and the other one is going to stay stable, then I would have implemented agents that might interfere with the bone marrow, with the suppressive bone marrow microenvironment. For example, agents that are interfering with the expansion of regulatory T cells, agents that can stimulate or expand the predominant naive CD8 stemness cells. And then, but I think that now, when we are gathering most of the patients together, and I don't think that we can identify high-risk SMM patients accurately. I think that when we're saying high-risk SMM patients, some of them are not going to progress. I don't think that the tools that we have nowadays to segregate between the patients are too accurate. But I think if we will have, the ability to sequence the patients, but also their immune milieu and come up with, some kind of signature and saying this patient is going to progress, then, these patients should receive early therapy. Because, for example, if you have a polyp in your colon, you're not going to wait till the polyp will become cancer. So I think that, we just have to try and find out a solution to identify this, to find a reliable solution to identify the high-risk patient and then provide therapies which interfere with bone marrow milia.
And concerning the very burning problem, mainly timing of vaccination against COVID, should we do it in each case? Because better do it than nothing, or would you have some advices, rational advices? How should it be done?
I can tell you what we are doing. We are telling, all MGUS patients to be vaccinated, all SMM patients to be vaccinated. Patients on therapy, we recommend them to get vaccine, but we also give them Evusheld in Israel because it seems to work also for the new subtypes of the Omicron or new of the Omicron variant. And I think it's worth doing it because, in the end of the day, despite the fact that most of the patients are not doing extremely badly, CLL patients are doing worse, lymphoma patients are doing worse, but still, MM patients are not doing very well. And accumulating studies published, also by our group, but by many groups, showing that patients with myeloma, have a higher risk for high-risk COVID. What is also interesting, I can tell you, when we did our study, and we didn't publish this part, but SMM patients succeeded to attain very high antibody titers, where patients with myeloma responded, but the antibody titers were much lower. In the SMM patients, the titers were in thousands, and in MGUS patients and in the active myeloma patients, despite the fact that most patients responded, the antibody titers were in hundreds. So the decline in antibody titer was also was rapid.